Correction of the conchal deformity. It seems that many patients who are dissatisfied with the aesthetic results of an otoplasty demonstrate residual conchal hypertrophy that was missed or ignored as an element of the initial ear prominence, or undertreated. When conchal hypertrophy is part of the deformity, it should be adequately addressed. The placement of conchal mastoid sutures alone is often inadequate and results in either immediate or late relapse. Conchal deformity can be addressed by several methods including suturing techniques, excisional techniques, and scoring. Suturing techniques. Conchal mastoid sutures can be used to correct conchal excess or prominence of the superior 2/3 of the ear. This suture technique was originally described by Owens and Delgado, 1955. Their method was subsequently modified by Furness, who used non-absorbable, full-thickness mattress sutures placed in the conchal cartilage, piercing the anterior perichondrium, and sutured it to the mastoid fascia. Spira and Stahl modified this technique to include a laterally based conchal cartilage flap that is subsequently sutured to the mastoid periosteum. This maneuver serves to bring the conchus closer to the scalp and thus reduces protrusion. This particular technique offers the advantage of a thick cartilaginous flap that can be more permanently and precisely anchored to the periosteum while decreasing the tendency to obstruct the external auditory canal. Conchomastoid suturing alone is rarely adequate to achieve an optimal outcome. Correction of the conchal deformity by excisional techniques. Excisional techniques can also be used to reduce conchal hypertrophy. These techniques can be grouped into those that excise cartilage alone, usually performed through a posterior approach, and those that excise skin and cartilage, usually through an anterior approach. There has been no proven advantage of an anterior versus a posterior approach. A posterior approach to the conchal bowl is described by Beasley and Jones. This technique stresses resection of the lower conchal bowl segment if the antitragus is prominent and thinning of the ponticulus where the postauricular muscle inserts. Elliott and Bauer both prefer an anterior approach because they believe that the extra skin remaining after a cartilage excision may not shrink down enough postoperatively to avoid leaving a visible fold in the conchal floor. The procedure I prefer for conchal bowl excess was described by Jack Edward Davis, an Argentinian plastic surgeon in 1978, and adopted by Joe Niamtu, 2011, and involves removing the excess conchal cartilage to reduce the hyperplastic posterior wall of the conchal bowl and reduce the bowl itself. In the Davis procedure, the hypertrophic cartilage of the posterior conchal wall and bowl are excised. It is this excess cartilage that makes the ear protrude, and by resecting the excess, the posterior conchal wall and bowl are reduced, thus allowing the ear to lie in a more normal position. A. An analogy to removing height from the posterior conchal wall and bowl. B. The kidney bean-shaped excess excised cartilage. C. The emesis basin posterior conchal wall and bowl is reduced, thus lowering the height of the basin or protrusion of the ear. A and B, the 8 to 10 mm marking is made on the posterior conchal wall, and the remainder of the conchal bowl is traced for excision. C, the needle tattooing of the kidney bean-shaped excision. D, markings on the posterior conchal region. A and B, the kidney bean-shaped excess conchal floor is removed with careful undermining. This leaves the dermal surface of the conchal bowl skin intact. Bolster sutures are placed through the conchal skin, secured to the mastoid fascia, and then returned back through the skin. Although 8 to 10 mm has been discussed as the average conchal bowl excision, each case is different, and it is better to err on the conservative side and leave more cartilage intact. Overcorrection is a common novice mistake. Correction of the conchal deformity by scoring techniques. Careful scoring may be used alone or in combination to reduce conchal prominence. Using the Gibson principle, the anterior surface of the conchus can be scored so as to warp the conchal wall in a posterior direction. This essentially converts the prominent conchal wall into scaphoid surface. Conchal cartilage is incised, dissected, anterior scoring, and then rising proximally based facial flap is advanced and reposed at the anterior surface of conchus. A. Postauricular marking. B. Excision of a small strip of skin. C. Curved incision in the conchal bowl extended superiorly, yellow arrow, beyond the extent of the skin incision. D. Preserving lateral conchal wall height at a minimum of 10 mm. E. Medial conchal cartilage flattened by anterior scoring. F. Medial conchal cartilage further flattened with radial scoring and absorbable sutures. G. Line drawing summarizing the operative steps. Wrinkling of the medial skin is avoided by ensuring that the lateral wall is set back at the edge of the flattened conchal cartilage. Tips. The cartilage preservation technique is more conservative when compared to cartilage resection. They are ideal for patients with flexible cartilage and minimal and/or moderate deformities. Excisions with partial conchal removals, addressed by retroauricular access, tend to have a guarantee of non-recurrence, with more predictable results of the distance between the edge of the helix and the retroauricular region. There are countless reasons to associate the conchus and antihelix correction. The eclectic technique removes the conchus along the suture of the remaining cartilage in the mastoid region, preventing the narrowing or collapse of the external auditory canal. The interruption of conchal cartilage makes its transition with antihelix less evident. Associated with the mustard sutures, they recreate the ear with a more natural and elegant appearance. The cartilage removal can cause a projection decrease of the antihelix. There is no consensus in the literature on the superiority of one technique. Toplu et al., in a study with 132 ears, stated that long-term otoplasty without cartilage removal and based on aesthetic results and patient satisfaction index, would be better compared to the technique with conchal removal. Compatcher et al. Also obtained similar results in a study with 281 patients. Panetier et al. Analyzed 104 ears and did not evidence long-term difference between the techniques. However, Bauer et al. Advocated conchal resection, because despite many techniques discuss antihelical fold as the key component in correcting the prominent ear, in his experience the principal cause is the conchal hypertrophy having a benefit with chondrocutaneous resection. Lobule positioning.